It's my great pleasure to introduce my good friend Gautam Madama. He's the principal microbiologist at KWR. He's a professor of water and health at Delft University of Technology. And he's been here at MSU as a distinguished HANA visiting professor. We've known each other a long time, and it's such a great to see how much his leadership has influenced what we do in water quality and health and public health. That's his passion. He likes to bring technology. He works with the industry. He has one foot with public health and one foot with the water industry throughout Europe. But he's also a leading expert now and recognized leading efforts in Europe. And he works with the Collaborating Center on Water Quality and Health with WHO, and also has been advising the EU on environment, on drinking water, water reuse guidelines, and now on wastewater surveillance work. So a little bit of a paradigm shift, but Gautam made it easy, and also he shared his knowledge early on in 2020 with us that really helped the Michigan network move forward. So it is so great for you to come over the seas and join us for this conference. So let's welcome Gautam.
Well, it's so good to be back here in Michigan. As Joan said, I've been working here, working with Joan already since 1991, and even before the PCR days, and also worked at the Michigan Department of Health. So it's super nice to be back, and I think my title is also about the value of partnerships, and I think seeing you all here today and from the different areas, because I think wastewater surveillance is really something where the water sector and the health sector need to come together, because the water sector sits sort of on the information and can collect it and has the knowledge of how to collect that, but it's the health sector that really needs these type of data and can inform about where is the value, what do I need, and how can you provide that. So seeing you from the different sectors sitting together is, I think, it's very nice and very important in the process of bringing wastewater surveillance forward. I'm going to talk mostly about COVID, but also move beyond COVID, as we all are doing at the moment. Starting with wastewater surveillance, I think I start with wastewater monitoring of sewage. Started here in the US, you see, in the 1940s during a polio epidemic, where the main question was, could there be transmission via the water route? And where you see the method, inoculation of rhesus monkeys, was still not a very fast method at the time. Needed a lot of monkeys for that. And the outcome was that, yes, you can transmit poliovirus via wastewater during an outbreak. So then for polio, it moved in sewage surveillance. So here is in the Netherlands in '92. We had surveillance of poliovirus circulation in at-risk communities. We have certain communities with a low vaccination rate because they are reluctant to get polio vaccines. So at the schools in these towns, the wastewater is monitored to see if there is actually to confirm that poliovirus circulation is non-existent. But yeah, you can also, if it starts to be existent, you can see early circulation of the outbreak virus. It worked, and it picked up the virus in the environment before the first case was recognized, but did that only retrospectively because the cell culture methods used at that time took around a month to complete the data. So by that time, the first cases were also reported in the community. But if we would have had faster methods at that time, we would have been able to sort of warn for the outbreak. And now sewage surveillance of polio is really happening in areas of the world where polio is still endemic, or where it is recently eradicated to confirm absence. So we had wastewater surveillance already in the world, still using cell culture, by the way. When we were facing, my team was facing the pandemic. I work at the Water Institute for the drinking water utilities, and the first question was really, a new virus. Is this transmittable via water? Should we be concerned for wastewater workers? And that was also fed by what happened with SARS-1 in Hong Kong, with the fecal droplet transmission of SARS-1. I think it could be possible with SARS-2, but only in these very special situations where you see fecal droplets floating around the building, like they saw in Amoy Gardens. But already early on at the pandemic, and I think all the years of the pandemic have confirmed that there's no epi signals or case reports that there's people that are particularly exposed to wastewater have a higher risk of contracting COVID. We see high concentrations in stool. We also see relatively high concentrations in wastewater, but it's the RNA, and it seems like the environment already in our intestines and also in wastewater is not very favorable for SARS-CoV-2. So what we are actually looking at is, I guess, some sort of virus corpses in our wastewaters. There have been groups that have been looking at wastewater and see if they could extract infectious virus out of it. And to my knowledge, not yet found. So it doesn't seem to be robust, and we advised already early on that the standard personal protection is adequate and is mostly needed for protection against other viruses than SARS-CoV-2. The question was also about safe bathing, safe drinking, and we concluded the same thing. So during the pandemic, things really went also in research and development at what I call warp speed here. We had, it's difficult to see, but at the end of 2019, there was the notification to the WHO of pneumonia in Wuhan. Then in January, I think, can do it here, 11, there was, it was identified as a coronavirus. Then at January 23, the first report was published for how to do diagnosis in clinical samples with PCR. And we had in Europe the first cases on January 31, and already in February 5, we were taking the first samples to analyze with qPCR. So you see how fast, I think, we all in the world, and I think Shannon also mentioned it, that many people devoted their time and energy to collect wastewater samples and try to find the virus in there successfully. So these were our early data in March of 2020. Here it was, what you see here is the wastewater data in the circles, and the number of reported cases in the lines in two different cities, and you see they went up together. So that's what we first published, and then we set out to make also a consortium like you have done with the public health side of things and health researchers, the water side of things, so the utilities. And the labs, and also the technology providers, and people that know about wastewater system or sewage systems. Because I think that's really the key to successful wastewater surveillance programs. So this is data that we collected for Amsterdam, where you see in orange the wastewater line, in blue the positive test, and in gray the hospitalization line. Well, you see how they go in parallel over the time. And you also see that there are diversions. I will go into that in a bit more detail later on. So we have a national program now that started up also early in 2020. And now all of our wastewater treatment plants, we are a small country, a bit like the state of Vermont, 300 wastewater treatment plants in total. We are small, so transport is relatively straightforward. We are in a bit of a good position to do it like this. But all the wastewater treatment systems are now monitored 3 to 4 times per week. And you see this is our national dashboard, and wastewater has also gone up during the pandemic from a sort of a side indicator to now one of the main indicators. So if you now go to the dashboard, you will see these are the 3 main current indicators that are used. So the tests, the wastewater, and the virus variants. And if you look at the test results over time, so these are the data that are collected. And yeah, you see the super big Omicron peaks here that really dwarfed anything of the alphas and the deltas. But if you look in the load in wastewater, you see, well, you do see the Omicron peaks, but they do show a bit of a different pattern. And although you do see something here, you do see things much more clearly in the wastewater. And if you look in the hospitalizations, you also see something, and you see a parallel that's a bit better with the wastewater data, although of course with the increased immune status of our population due to vaccination and natural infections, and the fact that Omicron is not as virulent as its predecessors, you do see that there was a big shift in when Omicron hit, and that the number of cases went up more drastically, but the number of hospitalizations fortunately did not. So you see that the relation between wastewater and hospitalization has also changed over the pandemic. It wasn't until Omicron hit, and because with Alpha and Delta and with the first immunizations, we did not see much of a difference in the ratio between wastewater and testing data and hospitalization data. Here is an indication that the wastewater data are also showing something that is more representative of what is actually circulating in the population. We have some 15,000 people in the Netherlands that self-report if they do positive tests. And well, you've also gone through this major testing programs through the health services and self-tests, and then you didn't go to the health service anymore to do the tests. But these people report their self-tests, the results to the health, the National Health Institute, and so you see here the changes over time in the self-reported test. But also that is sort of dying out in the sense that less and less people do self-testing. So actually we consider wastewater is currently the only, well, with hospitalizations, and maybe that's also the most important indicator, but wastewater is the only surveillance tool that gives us an idea about what is circulating still in our populations. In the city of Rotterdam, we made careful alignments of what we did above ground, so the positive tests in the population, and what we were testing underground. So you've been working in wastewater surveillance program, so you know it's important to, if you want to match data, you need to have data on the same populations. Otherwise, what are you comparing? So here it was possible to make very nice connections between the underworld and the above world, so to say, and to see if we could look at the surveillance pyramid and what we could learn from that. And of course we learned, and we sort of knew that already, that if you have sewage data, they are susceptible to what's happening in sewers. So some sewers may carry more industrial waters, some sewers sometimes get rainwater. So what you see here, if you look at the figure, the dry weather data, if you don't normalize or you do normalize via flow, it doesn't matter much. But if you have wet weather data with rain, you see that the flow normalized data really start to differ from the non-normalized. So you need to understand what is happening in wastewater to normalize the concentrations that you find for these factors. Then we also looked at, in the early days, we said, okay, wastewater is ahead of the positive test data. And that was, well, certainly in some of the cities, we reported first on the wastewater being positive before the health data were positive. But here we started to investigate what was our lead time in the wastewater. And initially, so this is the November 2020. So this is the second wave, still before Alpha was hitting us. We saw that wastewater, so that's the green lines, generally was earlier than the positive tests, and it was some 6 days ahead. But we also saw that over the pandemic, testing facilities were rapidly enlarged and testing changed. So what you see here is over the same period, so from June to January, so 2020, 2021. You see how long it took for between onset of symptoms and the day of the test was taken. So it was around 6 days in the beginning, and it went down to around 1 to 1.5 days in January when the test facilities were up and running. So what we actually saw was that wastewater was not early, but it was a positive test that were late. And if we were correcting, normalizing our positive test data for the first day of disease, the onset day, you get a very, and of course that's also what you would expect, right? If people start to shed high concentrations, get into the wastewater, and so with increase in the population incidence, you also get an increase in the wastewater signal. So that worked well for us for some time, but you already see that during Christmas there's a deviation, or just before Christmas. And we know that there were many people that wanted to know if it was safe to visit their family over Christmas. So there were a lot of people going to the test facilities before Christmas and less people during and after Christmas. So we think that's why we get this deviation. So again, an indication of changes in testing behavior, which may also lead to changes in your data on the circulation of COVID. So it started to diverge even further. And we also then included the number of tests as a parameter, because we saw that this varied over the, of course the percentage positive varied over time, but also the population tested varied over time. Here you see the pre-Christmas peak again. So if we started to include the number of tests that were taken, so the percentage of the population tested in our results, in our model, we were capable of getting much closer to a much closer match between the wastewater data and the positive testing data. And that continued on, even with the introduction of Alpha, which happened somewhere here, and the introduction of Delta, and also with the immunization started in this period. The only deviation we see here, and that is when our minister decided that for the youngsters that they could go party if they had a negative test. So we saw a lot of people showing up at the testing street that hadn't been at the testing streets before. So we believe that's why we see a deviation there. If we look for the city of Rotterdam and the municipal health service They also asked us, they said they had indications that in certain city areas there was under-testing. So we compared the wastewater in another way, so not looking at lead times, but we looked at the ratio between what you find in wastewater in concentrations, normalized, and what you see in the same city area. And there we saw differences, and we saw that in some areas we had less people tested positive than you would have expected from the wastewater concentration. So they use that as a signal to say, okay, that means that we have to increase the testing. So they mobilize test buses to the city area, launch an information campaign to get these people to the testing streets. Well, of course, you all know the variants of concern came in. We worked with the Bio-Rad people to work on a droplet digital PCR to try and find signature mutations of different variants of concern. This is our first publication on that, where we saw here in blue the wastewater of Amsterdam and of Utrecht. The data of N501Y, which was a typical alpha mutation. You see also in orange our national average data, and you see Utrecht was sort of on par. So the city was on par, but Amsterdam, they're always first. In this big city, the cosmopolitan city, this new virus variant was there circulating earlier than the national average, and you can pick that up also through the wastewater. So we saw the alpha wave, again on the left wastewater, on the right our national clinical surveillance of 1,000 or 1,500 patients every week. And here also for the Delta and for the Omicron. And if you look at Omicron, we saw something special, because there with Alpha and with Delta, the increase in the variant in wastewater and in the patients was on par, but in Omicron wastewater was getting later. But because we already knew, yeah, they should be on par. So it's not that you, if you have more Omicron cases, they also start to shed immediately. So what we convened also with other wastewater surveillance researchers, they sort of saw a similar thing. And what we think had happened is, because this is a relative scale, is that actually there is somewhat less excretion of Omicron through feces than of Delta. So that looks like it's later. So we could sort of roughly deduce that it was a factor of 3 less with Omicron than with Delta. So it means that you have to be aware of changes in the virus, because that can change your relations and the things that you see in wastewater and how you interpret that. Of course, we also did our sequencing together with Erasmus Medical Center. Here you see the variant of concern time in the blue, with 3 variants or being the most prominent. And then you see the big alpha wave. You see beta was trying to get in, but didn't succeed. And there you see the delta wave taking over in the sequencing data. So it's super interesting to see that you can also do this type of sequencing and viromics in wastewater. So there was a lot of press attention, which is super nice, of course, on wastewater surveillance, and I think everybody sort of, well, maybe not really in the beginning, but everybody sort of gets the idea. So it's relatively simple to say, oh yeah, I understand that you can do it. Joan and I and other workers, like Colleen Norton from the University of California, Merced, worked on trying to collate all these wastewater data around the globe. So this is what is happening around the globe. We don't have all the data, but we do have quite a big data set already from around the world. and you see the type of data that are in there. The data are downloadable, so it's really as long as the original data provider agreed to do that, to make them available. And we have use cases, and that's where I'm going to go into a bit more detail. Here is in Australia, which was long successful in keeping the virus out with strict import regulations, but the virus got in. And here in a town in Victoria in Australia, they were doing wastewater monitoring sort of to confirm absence, but they saw, here you see August 12, no reported cases, but there was a positive wastewater sample. So public health department was notified, hey, we have signals of COVID circulation in Shepparton while there's no cases reported. August 19, more positive wastewater samples. So it was used to inform the public and to expand the testing services. And obviously you could wait for it that August 20 the first case was reported, and that was used to make a lockdown decision and expand the wastewater testing to towns in the region. So this is about early warning and about to support outbreak response. Early warning of the health department to sort of get ready, and of the population to be vigilant and get tested if there were symptoms. Well, I've already shown this one about the under-testing in the city areas. In Switzerland, they test 6 cities, and they test their wastewater every day, and they sequence their wastewater every day. So there's a lot of effort going into what is circulating in the wastewater, and you see the types of figures that you get there from the wastewater data. So it was early detection of the introduction of new variant concern at a very high resolution of daily samples. Then in a really different setting in South Africa, where there's a lot of populations that don't have, that are not sewered or unsewered, and the South African researchers and the Water Research Commission there, and also the National Center of Infectious Diseases, they embarked on what you could call also wastewater surveillance. You see here draining streams that flow alongside these informal settlements, and where they installed passive samplers. I think I have the picture of the passive samplers. You see the streams. Yeah, here's the passive sampler. So a torpedo. I think many of you have also worked with the passive samplers. Torpedoes with the sampling material inside, and they were able to find the COVID in this in the wastewater of this population. Of course, the quantification becomes less quantitative, and it's more difficult to see which population you represent. But you have to also recognize that these informal settlements have very little access to normal public health, so the surveillance was not capturing these populations at all. So this was, for them at least, a way to get some information. So early warning, objective, everybody goes to the toilet and not everybody to the testing facilities. Efficient, low cost, versatile, at different, I guess you've all been through there. What I also see, and that's why I think it's so important that you are here together today, that collecting data from wastewater for public health support is atypical for the health sector, because they're not used to look into wastewater data. It's atypical for the water sector because they're collecting operational data for their systems and maybe some discharge data, but not health data. So it really, a lot of academics started, but when they had the proof of concept and the publication, it's not up to, they don't see it as their task to start to embark on surveillance. Then they move on to show something new again. But So what I see as the key elements of successful implementation of an action wall is where you have the bridge between health and environment. And in some countries that I know in Europe, like my country, but also other countries, there is a National Institute of Public Health and the Environment where there is already some sort of a bridge between the two. So that was really helpful. And I see that there are early adopters. I think you in Michigan here, but also the CDC with the news program in Australia, the Victoria Department of Health, and they were really, these departments of health were sort of taking over the steering wheel from the utilities and the academics and saying, okay, if this is a tool for me, I'm gonna also determine what I can do with the tool and what I want the tool for. So it's really there where the most of the benefits and the added value is seen. 3 minutes. We monitored airports to see if that could be something where you see something coming into Europe. We did it for the European Commission, and well, you will not find that easy to see, but what we saw here was that both in Frankfurt Airport and Schiphol Airport, we saw some introduction of Omicron before it was officially seen in Germany and in the Netherlands. So also airport wastewater can be a place where you can pick up something relatively early that is coming into your country. Was later confirmed in another study. So what next? Because the pandemic is sort of forgotten, not completely. There are still people getting into the hospital. But generally, we don't really think we are living in a COVID world anymore, although COVID thinks differently. But in the Netherlands, there's a national discussion about, okay, what else? What more can we see in? And here you see this is not what is actually going to happen, but this is for discussion on what can we do. And now then the main discussion is, of course, okay, but where is added value of taking wastewater data into account? So obviously a poliovirus, that was already an early one, but well, you've seen it here in New York. And also in London, it was observed that there was introduction of a poliovirus strain, and that started local circulation, and that was picked up through wastewater surveillance. And I talked to Susan about that it's interesting to see that you could say, okay, but then you can combine COVID and polio. But like I showed you in the Dutch example, for polio surveillance, we are focusing on schools in small towns. And for the COVID surveillance, we are focusing on wastewater treatment plants of cities. So it's not automatically that you can say, okay, we can monitor it. So that means that we can sort of make added value of our single sample. Monkeypox or Mpox in wastewater, I think here in the US it was also, this is a really short, we also did some testing, but also there the question was about the ethics of this type of testing, because we really had to zoom in on city streets, so we didn't follow through with the Mpox surveillance. Last January, we were confronted with a hepatitis A virus outbreak at a school in Amsterdam. Was imported by travelers from endemic countries. So the question was, are there asymptomatic carriers? There could be a long incubation time, so could we use wastewater to detect if there's silent circulation of this virus, and also to see if the measures that we take in this outbreak to control it are effective. So we had to design something where we really focused on the school locations. It's not so easy to see, but here you see one of the torpedoes in the manhole. This is the school. So you have to find the appropriate locations, and it worked in this situation where you can monitor the city sewer at a site that is representative of the school. So, and we use the passive samplers here. First thing to say is that we used crash phage as a normalizer, and you see that, for instance, here, the blue ones, you see more crash phage in your sample. So, and that was actually the part of the school where most of the outbreak occurred. And crash phage is then an indicator that, let's say, the fecal strength of that sewage that you are collecting is relatively high, higher, and maybe even tenfold higher than you have in the other samples. So you have to be aware that you sample more stool in those passive samplers. So you have to normalize your hepatitis A data also with that. So what we saw is that we did find hepatitis A virus in the school and also in the city area. And if we looked at the sequences, that's what our National Institute of Public Health did. They had sequenced the cases, and they found identical strains in the wastewater. It was strains that came from Somalia. So what we saw was that the outbreak was slowly fading away, but it was still there in February. But now what we see here in these samples is that there is another hepatitis virus, one from Morocco, but there is no reported cases, and it's a reportable disease. So, but apparently there's silent circulation of hepatitis A virus of this Moroccan strain. We are also preparing to see if we could use wastewater for human circulation of avian influenza. We are all scared of introduction of the H5N1 into the human population. Well, and maybe first the livestock animal population, but certainly also the human population, and that it starts to circulate in this community. So we think that wastewater surveillance could be an additional way to inform if there is or is not additional circulation of this H5N1. So we are trying to establish proof of concept for that. We are also working on scabies in student homes, and that is a bit atypical, but we are using the wash water of the student home as a place to sample, to get a proof of concept. That was really last week. We had a site identified, and the local public health department said, we would want to move in and do the sampling, but it was an asylum home for minors. So there was a lot of discussion about whether we could do that type of sampling. So again, you see that there is ethical considerations when you, so you can do things, but should you do things? Those are the questions that emerge, and particularly when you are confronting what you can do with reality in public health. Quickly go on more chemical things, illicit drugs in sewage. What you see here is a European-wide study that has been going on for more than 10 years to see where you should go to find cocaine in this situation. And if you go into Amsterdam, well, cocaine, you should go to Antwerp, you see here. But what you also see is that you can see, well, after a bit of a decline in the COVID pandemic, but you do see an increasing trend, and you see it's a weekend type drug, and we do this for MDMA and others. But you can also, well, you can even evaluate market sizes from sewage data. But here, this is a study from North Carolina where you looked at opioids in wastewater, of city wastewater, where you can also see what are the levels of the use of opioids in these communities and which type of opioids are used. So there is a recent this year's publication from the CDC on should we consider that we add opioid monitoring to what the wastewater utilities are already regularly monitoring. So I think another example of where you can get data at a relatively low cost and low invasiveness on what is happening in the population. And yeah, I promise you the example from Flint, because it was also very interesting. I think you are all aware of the Flint water crisis in 2014 and 2015. And what the group of Mark Edwards from Virginia Tech did was to look at stored samples of biosolids of wastewater and to look in the lead and also the cadmium concentration in these biosolids. And it's not so easy to see, but in blue that's in the biosolids. So what you see here in 2014, concurrent with the change of the water, that there's a clear increase, but then it dropped again, and 2015 does not really show a difference with the rest. But what you also see here in 2011, there is much more lead in the biosolids in Flint. So an indication that there has been a lead source for the people in Flint, and that showed up in the wastewater. So a nice example, I think, to use wastewater data, wastewater biosolids data, and also retrospective data to look at the exposure of the population to contaminants. And yeah, of course, the contaminant of today is or actually of the last decades, and probably the next centuries is going to be PFAS. There are people talking about, could you use wastewater also to say something about PFAS exposure? I have not seen studies that really said, okay, we can look at exposure data, but here, and there are some other studies as well, what you see is that you can see that the total PFAS in the populations they monitored were going down. They also saw some change in the type of PFAS because of the policy changes. So you can see if your policy is effective, but you also see that industrial discharges can really sort of dwarf what is coming from domestic sources. So you have to be aware of these other inputs. So really, I think you can do it when you know your system very well. So I think from my perspective, we have a bright future ahead in more than only the wastewater surveillance perspective, but certainly also in that perspective. But it is also, I think, up to us to find where the connection is between the water and the public health sector. So these meetings like today and making sure that these connections are sustainable, they are really important for sustainable wastewater surveillance program. And yeah, we are trying to see if you could use also global wastewater surveillance to say something about what is happening around the globe in terms of infectious diseases and also in antimicrobial resistance. And there are studies on that, and we are starting a study to look at transport hubs to see if you can use that to see a global early warning of the next pandemic coming or the next outbreak, the emerging pathogen coming. So the idea would be to have a global disease surveillance pandemic sentinel system through these transport hubs. And with that, I thank you for your attention.
Key questions, so please use the mic. Just stand up. Yeah?
So in terms of using, let's say, airport surveillance, you mentioned Frankfurt and Omicron. Retrospectively, did you see Omicron prior to the South African report? Or do you know of other places that also saw that? I'm asking that with respect to the fact that a lot of places shut down transportation from South Africa And I'm wondering if that was the correct action.
Yeah, we didn't see it in our study, and I'm also wondering whether that was the correct action. I think with coronavirus, we were sort of always too late. The virus, I did mention, but I showed the first reported case in the Netherlands was February 27. Later on, a retrospective study indicated, it was a couple of weeks earlier that we already saw people with the symptoms in hospitals, and that we could have diagnosed them with the COVID. So, and I think with Omicron, and also we saw that the first reported case was also preceded by many other cases that were retrospectively seen positive. So I think Omicron was out there already when we started to ban the South African flights. So I think maybe, if we would have, maybe for other viruses where we are better on time, then we could have stopped it. So if the virus was like SARS-1, I think it could have worked. But with SARS-2, he was too fast.
So in the early 2000s, I worked at an environmental testing laboratory, and one of our clients was actually Porta Potty company, and we did testing on that and found mercury off the chart, lead off the chart. Have you seen any studies of people testing those kind of samples? Because you could get festivals, concerts.
Okay, no, I've seen that people have been looking at these for COVID studies to see if they could monitor festivals, but I have not. Maybe there are, but I haven't come across publications to monitor specifically in those. And of course, there's also a lot of. We are currently discussing with the World Health Organization on. For instance, cholera in Turkey, in the outbreak-stricken area, and also cholera in Ukraine. But certainly in the Turkish area, with all the informal settlements that are there now, maybe it's also you have to come up with a way to do population type sampling, and maybe you have to sample a selection or each of the latrines or the porta potties, or to get a representative sample. So I know they're working on it in Turkey, but I don't think they have really started up the surveillance yet.